Okay, thanks, Theo. Hello, everybody. Nice to be the first to talk on the second day of UX healthcare. My talk is all about how our service design approach is helping to eliminate hepatitis C. Let me explain who I am. I'm a design consultant. I'm currently working for Nuom, who are a product studio wanting to become more of a full service design agency. Please get in touch with me via LinkedIn or ping me an email if you have any questions as a result of this talk. If you don't want to ask in the round, that's fine. I'm more than happy to take questions when I'm done. I've also got a lot of content, probably too much content. I always have a tendency to do this. However, despite the problems incurred, as Theo's just outlined, maybe that's not a problem. So we'll take our time, and I'm really happy to have questions. If you want to interject, please do. I know people don't like to do that, but I'm really happy if we keep it conversational. Okay, let's go. So I'll start off by just setting some context. So hepatitis C is actually a relatively little known condition. It's a bloodborne condition that affects the liver. General understanding of it in the UK actually remains still quite low, which is part of the problem. Often it's not that serious, but it can, over time, if untreated, become quite serious and even life-threatening. And in 2019, there were 118,000 sort of chronic cases in the UK. And now obviously we're looking to reduce that continually. There's also, as I'll come on to talk about in more detail, there's a misnomer that treatments are pretty horrific, and they used to be, but actually it is possible to cure, but there is no effective vaccine, which is why there is a focus on an elimination program. On which note, the World Health Organization is aiming to eliminate hepatitis C globally by 2030. This picture here is a screening center in Egypt. Egypt happens to be one of the leading countries in their progress for elimination. They used to have one of the highest rates, but they've done a fabulous job of focusing on their elimination program. So they're one of the trailblazers that are looking to sort of hit that target. And also of which is the UK. The UK, in fact, is looking to bring their elimination target forward by 5 years to 2025, which is very ambitious, but they're on track to doing that. And today, my talk is all about how we played a significant part in trying to achieve that goal by a home testing online self-order testing kit. So one of the big issues is getting people tested in a similar way to COVID. There's the need to understand where the risk areas still are, even though a lot of people have been found. We're trying to find the missing millions, as the campaign in the previous slide described. So that's what we're focusing on. That's what our job was to do, was to focus on the development of an online self-order home testing service. So just a brief note of the collaboration that Nuom worked with. Obviously, it's an NHS project. It's an NHS England project. They're the program owner. They also run the operational delivery network, and they coordinate all the campaigns. And it's specific to NHS England, I should point out. It's this is a campaign that's England specific. It's not in the rest of the UK. And then, as I explained, there's us. Now we're a product, we basically focused on the discovery and alpha, which I'm going to go into much more detail in throughout the course of this talk. We then work with Preventex. Preventex are incredibly important in this role because not only do they develop the portal, they effectively do the beta to get the portal sort of up and running. They operate the testing service. So they send out they get the orders, they send out the kits, and they receive the kits, they do the sampling, and then at the point of test result, then it gets passed over or not, depending on the outcome. And then another really crucial component of this partnership was the Hepatitis C Trust. Now they're the subject matter expert. They also provide peer support as part of the operational delivery network. but also they were incredibly instrumental in providing user research recruitment in a very challenging time frame. So big thanks to them for that. So that was the sort of the four-way partnership of this project. So yeah, so around end of October, we got a brief to say you've got 10 weeks to get something into development, which is quite challenging because it's a discovery and an alpha. So that's quite a condensed time frame to do both of those phases. Usually you would have not a dissimilar time frame to do a discovery and an alpha separately. But anyway, we rose to the challenge. It was a good challenge. So the approach we took was to run as much research as possible, and I'll go on to talk about how we decided on our research methodology. But we really wanted to cast the net wide, given that it was a population level problem, albeit in the timeframes that we had. We then were able to sort of narrow that down and focus on a prototype solution, which took us into alpha just over a month later. We then obviously prototyped and tested that through a couple of rounds and refined that down to a spec that was robust enough to go into beta, of which we then sort of handed over to Preventex to build that platform and to go through some various iterations to get it to the point where imminently we're looking to go live. I don't have a date, but it's looking to go live sometime later this month. But that's very much a current, but it is very imminent, and it's as you'll see from the demo at the end, it's pretty much there, which is fantastic. So first I'm going to talk about discovery, and then I'm going to talk about service blueprinting, and then I'm going to talk about the alpha. So discovery, the problem statement we had was, as I mentioned, we had a low level of awareness around hepatitis C across society. That was pretty much agreed. But we had different groups within that had different needs, different levels of understanding, and different digital capabilities critically, which is really what we wanted to dive into in the discovery time that we had. In order to improve the uptake in people that wouldn't otherwise be engaged in existing services like clinics or GPs, we needed to improve access to these self-order tests online, where people would receive the results and start treatment in that end-to-end process. So that was our problem statement that we were operating under. And our initial assumptions, I've mentioned a couple already, was that understanding and education around hepatitis C is low. Symptoms and treatments are not widely understood or even known. And there are associated social stigmas with hepatitis C, I should say. That it remains undiagnosed for many years, and that testing is inconsistent and often avoided altogether. And also, this is an interesting assumption that we were coming into, that Preventex have a great track record with sexual health testing, and they have a suite of services that that are third-party branded, and that we were operating under the assumption that we would follow a similar route, and that these services often have user authentication to require the test order process to complete. So those were our main assumptions that we were operating under before we started. So the risk groups that we were targeting, obviously we would have liked to have cast the net much wider, and indeed there's an ongoing program to make sure that this testing process is fit for purpose for a much wider general population. But the particular areas of focus for the particular people that are at risk are people who inject drugs, the South Asian community, people that have blood transfusions prior to September 1991, and the GB MSM, gay, bisexual, and other men who have sex with men community. So there's quite a wide, diverse range of use cases there, which is why we needed to go into it, validating those risky assumptions. So our hypothesis, quite straightforward really, to learn of the extent to which a range of potential risk group cohorts might be aware of hepatitis C, resulting in them actually taking action to order a kit. And our goals were to understand their differing levels of awareness, what triggers and barriers there might be to ordering, and then what level of anonymity and confidentiality they would need in sharing personal data, whether a sign-up process would act as a barrier, what support would be needing during the process, and what support would be needing ongoing when in the instance of receiving a positive test. And also we explored the need of whether the portal needed to be translated into either Urdu or Gujarati, given that there's one of our risk groups was from the South Asian community. Our research methodology, as unsurprisingly, because of the time we had, was qualitative, so it was rich, but the sample size was restricted. Actually, we were quite pleased with the sample size we got in the end, and I'll come on to talk about that. But we had we very much wanted a semi-structured approach so that we could explore the problem space in a much more detail rather than go in and validate a thing. We really wanted to understand the problem before before coming up with any solution. Even though we knew what the test, we knew we were providing a testing service, we didn't want to make any assumptions around how that looked. We had a pair practitioner process where we had a lead and a note taker on every engagement. But the real value of that is that you've got two people listening, and in a condensed time frame, you've got two heads auto analyzing all of the rich conversations that you hear through this qualitative approach, which is great. We had consent for anonymous quotation, which was really useful. We had a mix of remote, on-site, one-to-one, and group discussion, and we managed to get around the different locations as much as possible, which is great. So there was an ethnographic element to it, or a sort of contextual inquiry element to it. We had 1 hour interviews, or with the group sessions, they were up to 2 hours. So who do we speak to? We started off. One of the huge benefits of extending your reach when you're limited is to speak to healthcare practitioners who just live and breathe the front line all the time, and have access to people who have access to these risk groups as part of their job. So we started off by doing stakeholder interviews, which in turn gave us access to a service provider forum, which had a really interesting mix of charities, foundation trusts, the Hepatitis C Trust, and NHS England, and also Gilead, who are a pharma company working on campaigns to raise awareness around this, specifically around the South Asian community, and the Department of Health and Social Care as well. So we already amassed quite a nuanced set of information just from the stakeholder group as a proxy to the service, to the primary risk groups that we were targeting. And then we went on to conduct one-to-one remote interviews. We conducted a 10-person focus group in Leicester for people who inject drugs in a rehabilitation centre, and we also did another focus group in Bradford within the South Asian community, both of which were fantastic, greater than the sum of the people that were there. They were very engaged sessions. So we actually managed to get a reasonable geographical spread and a reasonable range of views during the time we had for this discovery. And the themes broke down into 6 areas. Unsurprisingly, general awareness came out, and we'll talk about that in a minute. But then trust and medical authority, and the extent to which language needed to be normalised, the levels of anonymity and discretion needed, and treatment. That middle 4, they were really interesting in terms of they busted a lot of our myths, so to speak. And then the 2 end ones were more predictable in terms of the way people would want to engage, and what kind of simplified user experience they want. If they were going to do something like a test, they would want it to be as quick and as accessible as possible. So I'm going to go into each one. I'm keen to share the detail with you because I think it's relevant and it's interesting. I won't, if I skip over some, it's just because I've got a lot of content. So the first theme, unpredictably, we did have most users did have a low understanding of what hepatitis C virus was, and few could distinguish between the 3 types of A, B, and C. A lot of people, pops slightly older, did associate hepatitis C or the symptoms of hepatitis C with they cited confusion with it's an unhealthy lifestyle, and indeed many people said that even healthcare professionals of old going back sort of 20 years or more, used to themselves conflate hepatitis C symptoms with an unhealthy lifestyle. Often people we turned away saying, well, you're probably drinking too much, that kind of thing. So that was really interesting, really important to dispel that as well. And as a result, I guess there was a sense of fear with getting it, because people didn't know how it would be treated, just because it's an unknown. With the PWID, with the people who inject drug community, there was a higher sensitivity to the social stigma associated with hepatitis C being linked to drug use. So there were more barriers there, which I'll go on to in a minute. But in the South Asian community, it was fascinating. There was a general agreement that there would be a high level of stigma associated with it, but actually we didn't find this. We didn't hear that a lot of people put any blame on the virus, but there was recognition that there were differences in healthcare practice between that in the UK and when they visit extended family in Pakistan. So that was definitely something that quite quickly challenged our assumption. And this range of quotes just speaks to the diverse different contexts by which these risk groups are operating under. We've got sort of fear of a legacy of, do I want to go through very invasive treatments, and what's it going to do to me, to the issue with the stigma and the barrier that the stigma creates, to just the lack of awareness and the fact that people, if they do know that, and they have been potentially exposed to less sort of robust healthcare practices in other countries, and that they would want to know. It's not a question of not wanting to know. So that sort of presented the problem quite nicely in those three quote areas. And the second point was, and perhaps unsurprisingly, that everyone said that they really, if they were going to use a service, they really need confidence that it was medically legitimate, and that they would see almost unanimously the sense that the NHS, regardless of what people's personal views were, the sense that it's a national institution that probably would have data on almost everyone anyway, gave people a lot more reassurance that they would want to use a service that was from the NHS rather than elsewhere, and that again, PWID. There was a unanimous recognition that the people we spoke to were still using, but they were on a path to rehabilitation. And if people weren't beginning on that journey to rehabilitation, they would be excluded, because there would just be too much chaos within their lives to think about using this as a service, which was useful to know. So it really makes us think about sort of what other mechanisms are there to sort of reach those people. And that just backs up what I was saying. Where it came from would be key in trusting the service, and NHS is trusted. And then normalised testing. This was a fascinating area. We sort of really went in there knowing that we had these different risk groups and knowing that we had these different areas, but actually people didn't want to be categorised. They sort of logically they cited COVID as a good example of very neutral testing. It's something that happened very quickly to everyone. And that normalized the process of dealing with it in many respects. And people used COVID as analogous to how they felt hepatitis C should be considered, in that there needs to be just simpler language around getting tested, and therefore there wasn't any particular focus on targeting a risk group, even though risk groups do need to be targeted. The language around it needed to be careful and neutralized, so that it wasn't seen as a taboo, an us and them thing. And then there's great with COVID, there's testing and information everywhere, but with hepatitis C, there's nothing. It doesn't matter how you got it, just get tested. The third point was also a challenge, presented real challenge in terms of how we developed the resulting service, because unsurprisingly, almost all users preferred to submit as little personal data as possible, even though in this case, when we compare it to COVID, that there is a need to provide some data, because there's an exchange in the way that the kits get sent out and then returned and have to be tested. So there's a recognition that there's a process involved which requires data capture, but obviously levels of anonymity desired were much higher. And some users did actually express value in the discretion afforded with online self-testing, because a lot of people, because of the stigmas that exist still, they didn't necessarily want to go and talk to someone about whether I might have it and get tested. That if the opportunity was to get tested in a more discreet way, then some people said that they would actively take it because they saw the value of that. Yeah, maybe it's worth pointing out again that the PWID group were more pragmatic about sharing personal data. There's a contradiction with that group actually, because they genuinely were more reluctant to share data. But if in an offline setting it meant getting a prescription, then they would be happy to share some data in that sort of in that implied sense of, well, if you just don't ask and I'll don't ask the question, just imply that you need to give it, then I'll give it, because there's a value exchange for that personal information exchange. So there's an interesting point around, and we'll come on to talk about how actually in testing that the way that people saw information wasn't actually as disruptive as they thought. Even if people around know I'm using drugs, I don't want them to know I have hepatitis C, which is really interesting in terms of how linked that stigma is still to the people who inject drugs group. The fifth point was that most users were unsure of the process of effectiveness of treatment. So this was really, we really majored this, and I'll come on to talk about how important content design is when designing a service. But the reassurance needed around, well, what if I got a positive result? What would I have to endure? And people weren't aware that actually treatment can be quite quick now, and that if they did receive a positive result, they would want to speak to someone to have that reassurance and know what the resulting process would be. Better deliver positive results in person via a phone call so that you can understand what the next steps and ask questions. And then a simple user experience. I think the key point here is that almost everyone said that by default they would want to access this on a mobile device. So it was essential that we took a mobile first approach, but not to develop an app, crucially, and that they would really want to understand the testing process before committing to an order. So that immediate sort of, what's the job to be done, what's expected of me before I commit, and then when I commit, I want to get through it as quickly as possible. So there were quite a few UI challenges that we had to overcome, but they were good challenges. Also, the use of visual aids, and really not sort of really being mindful of lengthy pages of text would be off-putting, and then people would need to know what the data asked for is being used for. Need to make the user flow as non-threatening as possible for scared users. That's an interesting point. The fact that they might even see this process as feeling threatening was interesting. So that we were very mindful of that when we went into the the flow and the calls to action. So our user needs, quite straightforward really as a result, but they allowed us to be really clear about what they were. So I need to understand what hepatitis C is. I need to know it can be treated and how long that treatment will take. I need to know if I'll put other people at risk. It can be passed on through family lines. So that was an interesting sort of slight edge case. I need to be reassured that the testing service is official and trustworthy. I need to have the choice of what personal information I submit. I need to know what to do and who to speak to if I get a positive result. And I need to know who I can speak to if I'm unsure about testing and treatment. So that gave us a good position to start really prioritizing down our feature set. And just a note on digital access needs. It's really important to note that in our problem statement, we sort of outlined that people would have different digital capabilities and different digital contexts by which they're going to be accessing this. And indeed, I've mentioned it, I've touched upon it briefly, but there are more significant barriers for people that are in the process of regularly injecting drugs, because they have impaired cognition, they have a degree of chaos, and this is their words, they have a degree of chaos in their life that sort of creates other priorities, and often they don't even have access to tech hardware that would allow them access to the service. And that we did hear about a higher mistrust of digital services that require some sort of personal data input. So that was, we needed to be mindful of where the boundary was between a sort of realistic interaction with a digital service and where an offline intervention was needed. We did speak to people with dyslexia, and they were particularly calling out avoidance of long pages of written text, and again sort of cited where with visual aids would also assist in understanding of the instructions, and not just the wayfinding around the service, around the portal itself, but actually understanding how to take the test when it arrives at their home, and how to send it back. So I've mentioned risky assumptions. We had a list of assumptions that we went into discovery with. Interestingly, some of those invalidated with quite a high level of confidence, especially the one around users want to register for an online testing account. There was absolutely no evidence to say that at all, quite the opposite. There were some interesting points that didn't validate entirely, and that just meant that we took those forward into alpha, along with other risky assumptions that we'd seen, especially around the way that eligibility and triage of information would come through. And also there were some questions around how the handover would work to the network to go and start the treatment pathway. So it was really important that we carried these assumptions, and we were very transparent about these assumptions and whether we were validating them or not, because there were two or three really key assumptions that we invalidated that really sent the development path down a completely different route. So in other words, we knew very early on that this couldn't be a third party branded solution. This had to be an NHS branded solution, and that meant an entirely different sort of approach. We needed to be assessed to the service standard. We needed to use the NHS guidelines. So that was really, it was such an important process to understand that before we get anywhere near a prototype. And before we got into the prototype, the bridge between armed with this information, armed with this discovery insight, and sort of launching into an app or a portal design, we really looked at the end-to-end. So we ran service blueprinting workshops, and these were great because I'll go into more detail now, but you've got the stages of the journey across the top in the grey boxes, and then you've got all the touch points with all of the different actors and processes that are involved in making this work. And it's not just the use of the online digital service, it's getting people to it. It's processing the online offline exchange of the test being ordered, the test arriving, the test being sent back, the notifications to ensure that the test has been received, the test process, giving the results, what happens when you get the results, what if I want to speak to someone. So there's all sorts of dead ends here, and there's all sorts of processes that have to fit, and they're all being conducted through through an interconnected partnership of people. So it's really important that the service blueprinting is so important to make sure everyone knows what needs to happen in order to get this end-to-end journey to work. Otherwise it'll just fall apart, and you'll design an app or you'll design a website, but if the service provision behind it isn't set up and isn't agreed and isn't bought into by all of the people that are providing those different components of the service, then it won't be successful. So I'll break this down in a little more detail. So first of all, you've got the yellow swim lane at the top, which is the customer touch points. So that's right the way from awareness all the way to treatment. And it's really important that you see what considerations they're having there, rather than just the interactions that they're having. What are they thinking? What are the potential drop-offs? And on that point, then the next swim lane is pain points. So these are really important to call out where the barriers might be along the journey, and how we can mitigate against those. Then you've got the front stage. So the dark blue line is the Preventex. So they provide the service, the testing service. Now they're crucial because they're managing all of the logistics. They're receiving the orders in, they're sending them out, they're validating the address, they're making sure that the test can be conducted easily, that there's clear instructions for the test. They're making sure that people know where to send the test back. They put it in the lab and they analyze it, and they get a result, and they're communicating that back to the user. And then alongside that, there's the support line, which is the Hepatitis C Trust. So they provide expertise. They also provide peer support for the network, but they also man a helpline. So if people at any point in the journey are unclear about what they're doing, or they feel nervous about the process, they can ring a helpline which is manned by the Hepatitis C Trust. So that very much leaves Preventex to get on with the testing process, and the Hep C Trust pick up the sort of surrounding support. And then you've got the backstage, which is NHS England. So that's primarily to pick up the treatment pathway towards the end, but it's also crucial to use their existing channels to raise awareness and to promote campaigns alongside their own partners that are helping people to get to this, because awareness is low. So, you know, it's only as good as people knowing that the tool exists in the first place. And the final lane, which is more peripheral to this project, but is UK HSA. So they have a duty of care to increase public health protection. So the data that they can get from this is hugely valuable to understand trend and to understand how well we're doing in terms of elimination. And indeed, at the beginning, there was a tension between what they wanted and what we thought we could get, what we thought was appropriate. And in the end, in the way we iterated the eligibility and the triage information capturing process, we ended up sort of getting good data that tested well, that was acceptable to users, that was also sort of hit the criteria that they wanted. So at one point we were saying we're just not going to be able to give you what you want because it's just going to be a fundamental barrier. So we managed to get around that problem, which was good. So this is a really key stage. I can't stress this enough, how I think in a lot of product design environments, the end-to-end nature, that solving a whole problem gets deprioritized or gets overlooked, and we wouldn't feel comfortable going into committing to developing a product and to start putting code behind something before we knew that we were going to solve a problem. And indeed, in the GDS service standard, or in the NHS service standard, it's one of the key criterias to, I think it's point number 4 or 5, that says, have you solved the whole problem for the user? So that's the focus on that is important. I've talked about this before, so it's just worth noting that on the subject of solving a whole problem, the operational delivery network is such a huge crucial connection point from the digital journey to the offline journey, this just sort of reiterates why service blueprinting is so important, because there's a real need for the human to pick up that, and for that reassurance to be then continued through the treatment pathway. If that ODN element of the service life cycle wasn't in place, then we wouldn't have designed something that was fit for purpose with that pickup point. So I just wanted to express that, and also it just sort of shows how you go from a digital remote service, which has its benefits and has its sort of challenges, going from a very physical interaction, that those two things can be quite jarring if they're not seen as a whole journey. So that gave us a great that put us in a very good position to commit to alpha. So we then went into more conventional process. So we looked at the flow of the portal itself. So now with confidence we could really zoom in and go, right, okay, what does the actual information architecture of the website need to look like? So we mapped out the IA, the flow and IA of that. Then we storyboarded the portal process, particularly focusing on triage and getting people through the order process. And then we came up with our Sprint 1 prototype. So this, as I've mentioned before, this was being designed right off the bat to strict NHS look and feel guidelines. So we were quite restricted in that respect, but that was a challenge because we needed to get as much information with as much clarity, with as little density as possible within the framework that they set. We went mobile first because we had such compelling evidence that it would be, almost always used on a website, on a mobile. But critically, it wasn't an app; it's a responsive website, because we didn't want to limit that to mobile. We wanted to make sure that it was accessible across all viewports. But we started with a mobile first approach. So we ran our first prototype. The testing goals were quite straightforward, really. How clear the purpose of the testing portal is fundamentally. What the calls to action, was the information hierarchy correct to understand the flow of, can they orientate themselves? Can they quickly find out what the testing process is? Can they just order the thing? How trusted was the process in terms of its look and feel, and the way that content was being displayed, and the way that information was being asked for? So we also just had to make sure that content information that people were providing, they knew what would happen when results were being displayed to them. So we tested a first round. We had a representative spread of the risk groups that we'd used accessed in discovery. And the headlines from round one was that luckily it tested really well first time. I think this is a massive testament to the team. I think the alpha team grew from Nuom's side. It was me as the lead consultant working with a product manager with the Preventex team, and then in alpha we got a content designer or a copywriter who was excellent, and an interaction designer, and those skills working in collaboration were brilliant, because we had great content design focus right from the get-go, rather than just putting in loads of stuff and just continually trimming it down. We really had an empathy with the discovery. So the first draft content was written with a lot of discovery value in mind. The additional information about HCV was actually really reassuring and understood. And it was interesting. I've tested so many products online in my time, but I rarely see people read every single word of every single page. And in this, because the copywriting job was so good, people read every word of every page, which is absolutely fantastic, because you usually don't in a test. They usually just get the idea. The information was seen as appropriate and non-invasive, which was great. And again, that point around the discretion afforded by the self-testing process was highlighted. So some quotes. Ease my anxiety. So where there's anxiety, because it was so straightforward and clear and trusted, I think people felt like they would be inclined to use it. They wouldn't sort of be put off by something that was unknown. People spoke about the nice and straightforward, neat layout. Also the fact that it was cutting out time wasted having to go somewhere physical was a value. No problem with sharing my data with the NHS. There was I'll come on to it in a minute, but there was some interesting form design challenges that we had to iterate to get people to sort of pick the right option, especially around possible transmission route. So that was just saying that there was good options to sort of not pick the one if they didn't want to. So yeah, generally tested well. Now, where we did change, and this is the important bit, because this is the stuff that testing is for, was that even though the first round copy was great in terms of its clarity, it still was ambiguous. For example, with the service name and the introduction, people just didn't understand necessarily that it was a home test kit. So it's just an amazing example of how you can think you know your subject matter, and there's so many people informing. Hepatitis C Trust with the subject matter experts were informing the content creation, but still we got it wrong, because people were like saying, well, what happens then? And so we had to change it from get tested for hepatitis C to get a free home test for hepatitis C, just to be really explicit, because this is sort of stuff that people just don't want to do, and they don't know that they need to do it. So it needs to be really explicit. So that was our first copy change. Another copy change we made was the more clarity and reassurance was needed around treatment process, especially when people had some, even if it was some erroneous awareness of the fact that legacy treatments were really invasive, they needed to know that actually now it wasn't going to be invasive, and also they needed to understand the severity of not getting tested if you test positive. So that level of clarity just needed to increase a little more. And this was an interesting one. So this is the biggest form element in the triage process, which and this is going back to the UK HSA. This is really important for them to understand what the transmission route is. Now, obviously, this is where knowing that hepatitis C has stigmas associated with it, this is where it can get quite tricky. But just in adjusting a few things around, it was amazing how much better it tested if you, for example, change the list so that the most stigmatizing examples don't come at the top, like drug paraphernalia, like giving clear options to say I don't know or to prefer not to say. It's really straightforward stuff, but it tested really well because people mostly understood why we were asking this. They understood that it was valuable, even if they didn't necessarily want to answer. They had we had a mechanism of basically allowing people to bypass it, but actually most people were happy not to bypass it. They just didn't want to. They wanted to, in the spirit of it being neutralized, they wanted to see that this was a range of problems that affected a range of people, and actually weirdly the list in itself destigmatized and decategorized a lot of people, because suddenly people realize that, oh, you can get hepatitis C from lots of different scenarios, not just from some of the more socially stigmatizing areas like sexual activities or drug taking. You can get it from a whole host of reasons. So actually, in the end, this question that we thought would just be a problem wasn't actually so much of a problem. Then there was clarification around the test results, and there was some antibody confusion. Some people sort of had the danger of knowing a little information, and we needed to be really clear about it was an antibody test and an active hepatitis C test, so that it was really clear about what the test was actually giving you, rather than some people thought they had to do a test and then a test. They also really wanted to be clear about what would happen in the different scenarios of a negative and positive test as well, understandably, and it was just a bit loose in our first pass. Simple UI stuff like these. This is the testing process, which was very clear, but the boxes made it look clickable. They weren't clickable, so we changed the UI so that the testing process was unambiguously information only before you proceeded. Primary navigation, order, and labeling didn't test too well, so we reordered that. And that took us into sprint 2. So we did another round because it tested so well. We were able to really focus in on the areas that we changed, just to validate those. We also at this point came up with an Urdu version of the prototype. Now this was quite challenging because the whole sort of shift in orientation meant that we had to completely realign stuff, and we needed real help in actually understanding how to lay out the syntax of it, because it was just none of the team spoke Urdu, but actually the first pass of it tested surprisingly well. So the second round tested well, continued to test well. The first early version was broadly understood and clear enough not to present any major barriers, which is great because we were limited in time and we didn't have, we had to be quite quick about the way that we used we translated it. And actually the first round of testing just it sort of created nuance changes and things that would definitely would confuse, but fundamentally would be usable, which was great. There's further validation that it was allaying current levels of stigma-derived sensitivity, which is great, because I think I made that point around the form design, but just the way that people were seeing it as more and more normalized was good. It was going in the right direction of not actually calling people out, but making it feel neutral. And the extent to which it was seen as beneficial and non-judgmental to South Asian risk group was also confirmed. And on that, we had further access needs through our second round. We sort of learned that actually there's quite has a low levels of digital amongst older generations. There's lower levels of digital literacy, and that there can also exist a lack of education when it comes to digital access. So that was really useful to hear and to understand that actually, even though we created an Urdu version, in many cases, people that would need an Urdu version would often ask a younger family member to use a process for them, and they may do that in English. So it's really important not to push that, but to have that toggle between both languages. So feedback from round 2 looks clear and simple. PWID and chemsex community would definitely see value in this, and that's because they still felt that there was quite a large level of discrimination still exists, and that sort of remote, the anonymous nature of it would be really helpful in circumventing that. Really good to know it's not interferon. Interferon was a legacy treatment drug, which was successful but quite invasive, and having tested and understood what the treatment process is, that was seen as hugely valuable. This will work great in the South Asian communities. Pictures will help people who don't speak English very well. Yeah, and I would definitely consider doing this test. So generally, it was testing. It was continued to test well, which was fabulous. And then changes from round 2, we made some really stupid mistakes. Like, for some reason, we had the gender selection as a checkbox. Why we did that, I don't know. It's just probably one of those things that nobody picks up, but then you test it, and the value of testing is that why can I select more than one? So we put those into radio buttons. And then a critical one was we gave the option to allow people to receive notifications of both mobile and email, but the way that the treatment pathway works on a positive result is that they have to receive a phone call. So the phone is default, phone is compulsory, but email isn't. So there was just confusion when people said, I would prefer to receive my results with email, but actually, if they get a positive result, they're going to get a phone call and they're going to get a text anyway. So it was just confusing. So we made that a lot simpler in terms of the sort of the mandatory and the additional optional. And then Urdu, we went through and we changed a lot of it. We had to do side by side in Figma because it was just impossible to work out where we made our changes. So we went through and made, most of it was nuance, but as you'd expect, just repeat words. Some words in our language didn't make any sense, so we just went through and corrected those to get it to the point where it then tested fine. The odd thing might be seen as sort of a quirky nuance, but it was testing without confusion, which was great. And then that's brought us up to today. So this is our current version. It's going to go live soon. We don't have a date, but it's now, this is operating as this is the current prototype. So this operates as a responsive website. You can now see this in desktop format. There's the ordering process. If I click order a test, I go through, I put my date of birth in. It's worth noting that the reason we asked for this is because it's for over 18s, because of safeguarding issues, it's for 18 and over. So they do have to qualify that you're old enough. It also has to be, there has to be an eligible British postcode. So you have to do your postcode and find your address. I put my gender, and then I have the transmission route, and then I put my contact details in. I have to confirm that with an access code just to sort of do that sort of secure handshake, and then I put in my address and I order the test. And then once the test's been ordered, then I get clear information on what happens if it's a positive or negative result. And it's worth just noticing we have more information on the testing process. These have got clear visual symbols as to what's going to be contained in the box, process of doing it. We have video content that will guide you through that if people are still unsure with the written instructions that they receive. And then there's more about hepatitis C, which also tested very well in terms of what it is, whether you need a test, how is hepatitis passed on, and the treatment that you can receive. So this is pretty much set now. This is ready to go into testing, and I'll stop talking because I've gone over. Been talking for nearly an hour now, so I'm going to stop. Go back to my slides. I think that is the final question. Yeah. Does anyone have any questions? There's a lot to take in.
Thank you so much for that, Alex. It was great. Really appreciate it. Let's just give it a couple of minutes just to see if anybody's got Q&As before we jump onto our next talk. How could anybody get hold of you?
If they want to get hold of me, then hang on. Let's go back to the top. So got my contact details here. So yeah, LinkedIn, or drop me an email. Either way is fine. If people are interested to talk about this, in a different setting, I'm more than happy to go through it. It's a really interesting project, and happy to talk about it in more detail.
Well, thank you for that. Really appreciate you stepping up to the plate and moving your talk forward. So thanks again to Alex, and we'll see everyone at the next talk. Cheers.
Thanks.